That sounds more fun.
Right? Oh, that'd be great. Here we go.
No, I think that'll be. Can you guys see it okay? What's it more, or we could leave the rest of the way on, or maybe.
Just make it.
Yeah, you got time.
All the way? Yeah, just.
I think.
Is that a camera?
What?
That's good.
So I gotta keep my snarky comments to myself. Huh?
All right, great.
What day is it? Wednesday?
Shoddily done.
Tuesday was nice. Wednesday is great. It's beautiful outside.
No, it's not.
Unfortunately,
It's so beautiful. It's gorgeous. I can't stand it.
cannot be here. And so he's actually in a whiteout out in Boulder. So 5 minutes ago, I was tasked with introducing our wonderful speaker today, which we are so pleased to have with us today. And the main point that I'm going to miss some of the main guests, so please further teach yourself what I've done. But the main point is taking into consideration that she is currently the Director of Maternal Health Initiatives over at the Center for Global Health in the Colorado School of Public Health, or the University of Colorado.
Yep, correct.
And then she's also an OB/GYN and clinician at Denver Health, and she has also been running health worker training programs in Nigeria, Rwanda, Guatemala, Mexico, and today specifically we'll be talking about Nigeria. So please say anything else that I really missed in this introduction, and I really look forward to hearing.
So I also taught in the International Disaster Psychology program here for a couple of years. So we were, I myself with Dr. Schreiber taught the international public health course within that curriculum. So anyway, I love coming back to DU. And so today, has anyone gone to any of the MSF events that are going on this week? So Doctors Without Borders is in town, and they have a film that they're showing, and the last 2 days they've had recruitment events in East Film in Denver, and then the next 2 days in Boulder. So I got to get together with some of them last night, and it was a really interesting screening of their new film. It has a lot of great issues that you guys might be interested in. It's called Access to the Danger Zone, and I think after this tour, you should be able to get it. Get access to it maybe on Netflix or YouTube or something. So I worked with Doctors Without Borders last year, right around this time, for a 7-week mission in northern Nigeria, and we were at a hospital that was specifically a project that started with fistula repair and then extended into emergency obstetric care. And so I'm just going to talk a little bit about my experience up there. So first, we'll talk just about Doctors Without Borders. If you're not super familiar, it was founded in 1971 in the wake of the Biafra crisis in Nigeria specifically, which was when the North and the South were fighting, and there was a lot of food aid that was being held at the border between the North and the South by the government troops from the North, and so it was causing mass starvation amongst the children. And so International Committee of the Red Cross, they negotiate access to these zones by being impartial and being independent, but they also don't speak out against what they see going wrong. And so the doctors who started with Doctors Without Borders were actually part of the ICRC team down there and were unhappy that they weren't allowed to speak out against, in support of the patients and in support of the children that were really the victims of this conflict. And so they decided to break off and start Doctors Without Borders so that they could have a mandate that was a little broader and a little more liberal. But they still maintain the most important parts of the ICRC approach, which is impartiality and neutrality, independence from all political, economic, or religious powers, including the UN and many of those actors. They assist populations in distress, they abide by medical ethics, and as as volunteers, you make no claim for yourself, meaning you're not expecting any monetary compensation in return, and they will, in their best way, provide safety and housing and things like that for you, but it's not necessarily required of them. The way they are funded is very closely linked to their ability to act independently. They receive 91% of their funding from basically private donations. Most of those are individuals, but there are some corporations and foundations that make up that portion as well. Then certain governments that allow them the independence to act as they wish, they will accept some donations from governments, but that's a very small minority of the cases. They take physicians, nurses, surgeons, anesthesiologists, but they also take lab techs, pharmacists, mental health professionals, midwives, epidemiologists, and in addition, they take folks who are logisticians, so people who basically make sure all the medicines that we need are there at the site to help us function, that we have access to the lab tests we need, that we have functioning water systems in the hospital, that we have air conditioning in the operating room if we can have it, and that there's electricity in the hospital and things like that. So they also may be construction or architecture experts, and then finance and administration personnel. So I know you guys are international studies majors, so I'm sure you know where Nigeria is. But just to go over a few things about it, it's the most populous nation in Africa with 154 million people. There are 50 million youths who are unemployed, according to the World Bank. So a huge portion of their population is unemployed. The life expectancy is low on average, so only 48 years. And it has one of the highest economic inequalities in Africa and in the world. So, a little bit more. The recent violence, so the reason MSF is there is not because it was a conflict area specifically. The project started because of lack of access to services and specifically to treat fistula. But in the meantime, since 2006, there have been increasing conflicts in northern Nigeria, partially because the 2011 election saw the defeat of a Muslim North candidate. The way the political structure works is that basically they trade off. There's three main ethnic groups in Nigeria, and so they trade off the president every third election. And what happened was that the Muslim candidate from the north had actually died in office early. So basically his constituency didn't get the full amount of time with the benefits of him being president. And so then when the election came around and a Christian was then elected subsequently, I think there was a little bit of hard feelings about that. And so out of that, there was the regrowth, I should say, of an Al-Qaeda-linked group called Boko Haram, which means down with Western education. And they have actually long been operating in the north, but had a resurgence after this election. And they've been bombing mainly Christian or governmental targets in the north part of Nigeria. So Kano was an hour from where I was, and that was a main site of a lot of the violence that was going on. And so in the meantime, since I've left, there have been increasing kidnappings of foreign workers, and they even, like 20 health workers and people died during a polio vaccination campaign where, people were basically gunned down. So it's become increasingly dangerous. And actually the project that I was at has been closed to international staff. I think in March of this year, they closed it to international staff because of the safety concerns. So, why are the health outcomes so bad in northern Nigeria? Part of it is that, women are a disenfranchised group. The health markers for women in northern Nigeria, I'll compare northern Nigeria to Nigeria overall. So overall, there's only a 15% contraceptive prevalence rate, whereas in this country it's around 70% or more. Antenatal care coverage average, so basically prenatal visits, the population that gets 4 visits is only 45%, so a very small number. There's only a 2% C-section rate, which the recommended WHO C-section rate for maximum neonatal and maternal survival is between 10 and 15%. And the skilled assistance in delivery is really, really low, especially in the poorest quintile patients. You can see only 8% have a skilled assistant at delivery, and that's a doctor, nurse, or midwife. And you can see the institutional delivery, which is usually very closely associated with skilled assistance at delivery, is quite the same. So very few skilled assistants outside of medical facilities. Okay? The maternal mortality rate is 500 per 100,000, which is, one of the higher, mid to higher ranges for Africa right now. And if you compare it to the US, our rate is 11 per 100,000. In northern Nigeria, there are several studies that have basically shown that it's, double the average, so around 1,200 to 2,000 per 100,000. So that's about a 2% mortality rate, and you'll see in the statistics that that's exactly what I saw. So why is MSF there? I kind of referred to this already. There's a very underserved medical population with high maternal mortality and fistula. This hospital is the Ministry of Health Hospital, and MSF runs the obstetric ward, okay? And began as a fistula project and then expanded to hopefully prevent fistula in addition to treating fistula. So the statistics for the ward, basically we had 500 to 600 admissions per month, and like many of MSF's projects, you start the project and the number of deliveries just increases and increases every month. So people hear about your services and they start coming. There were 400 deliveries per month, and about 50% of them were complicated. So when they first started, they told the population around, you can come with normal deliveries, but we really prefer if you guys try to, only come with complicated deliveries. So there was some community education that went on with that initially. The neonatal ward statistics, the stillbirth rate was 15%, so that's a baby born dead. Whereas the neonatal hospital mortality rate was 45%. So basically, about 50% of the babies that we delivered died while in the hospital in the first few days of life. So the complications that we saw, the magenta bar at the top is other complicated deliveries, which include cardiomyopathy. So if you know anything about cardiomyopathy, it's a very rare condition. Usually occurs just after delivery or just slightly before delivery. It's like 1 in 10,000 in most places in the world. It's very rare. But in northern Nigeria, the reported incidence is 1 in 100. And so what's crazy is that we did see a ton of what appear to be cardiomyopathies. But in my experience there, I don't think they're quite the same definition as what we're calling cardiomyopathy here. So I think there's some other factors going on, and that remains to be seen what the actual cause is. But you treat it quite the same, and it can be very lethal. Let's see, anemia was a huge cause of admission. We saw people routinely with hemoglobins of 5. Which is basically a hematocrit of 15, and probably most of you here have a hematocrit around 42. Okay, so huge anemia problem, probably related to malaria and parasitic burden. Hypertensive disorders, so we saw a ton of eclampsia, so that's convulsions and hypertension in pregnancy, so that was kind of strange. And then obstructed labor, so people in labor for days, unable to deliver and requiring a C-section. Those were the main things we saw, and the main causes of death were hypertensive disorders, anemia, and the cardiomyopathies. But just to give you a sense of what life was like in Jehun, in the base, so basically we would get up, we had cooks that cooked our food, and so they would make bread every few days, and so you could make your own breakfast, and then they would make lunch and dinner. And then you have breakfast kind of with the team. You can see everyone gearing up there. And then you walked across the poo field. So you were allowed to walk during the day, and you would walk just to the hospital and back, so you weren't really supposed to walk any other places by yourself, but you could walk by yourself during the day to the hospital. The poo field was basically, so you can see the hospital there in the background, the yellow buildings, but this was just a big open dirt field that had a lot of bagged feces, basically. You know, people, if they don't have access to a toilet, they'll poop in a bag and then throw it. And so there were a lot of those. There were no toilets or latrines for the patients' families. So that was kind of their only choice. So sometimes you'd be walking through the poo field and you'd see people squatting and doing their thing. So, and then there were animals walking around everywhere. This was a goat in the passageways in the hospital, and so it's kind of entertaining. You'd be on your way to ward rounds and see the animals around. So these were the families, and they would just basically sit outside the hospital waiting to be called in when their loved one was delivering, and then come bring a fresh blanket and new clothes for the baby and things like that. And so and then if they needed consenting for a C-section or anything like that, they were handy and available if there was a problem. So you meet some friendly folks along the way. This was kind of the typical dress. Most of the women would be mostly covered. They could carry amazing amounts of things on their head, so that was always incredible. And then the midwives were fantastic. So they were really welcoming, and so these were a couple of the midwives, and they were actually from the South. So the education system in the North has been so deprived for so many years, especially in terms of women being educated, that there really are very few midwives who are from the North. So we did have nursing assistants who were from the area, but most of the midwives were actually from the southern or eastern parts of the country. So day one. Oops, sorry. Okay, so you walk in, you're assigned to the ICU rounds and annex rounds. You just finished rounding on a woman who had an eclamptic stroke. She has hemiparesis and is ventilating poorly and seems to be developing a pneumonia. That means she's basically unable to move one side of her body. Okay. You then go to your next patient. She's 16. She's a G1P1, which means she's had a baby. Baby's alive, and she's 2 days postpartum, and she was awake and responsive yesterday. And so then she was diagnosed with anemia and severe malaria postpartum when she was admitted. She was being treated appropriately with IV and then oral meds. Her fever had decreased yesterday, but it increased again today to 38.5. She's breathing in a labored fashion, is now unresponsive. You saw her yesterday, she was responsive. She's tachycardic, which means her heart rate is going really fast, and she has a blood pressure of 80/50 with dark concentrated urine. I know you guys aren't clinicians, so I don't expect you to answer these things. But so you want to think about what's her kidney function, what's her hemoglobin, what's causing her to suddenly not respond, and could this be a continuation or worsening of the malaria that she had? So there's something called cerebral malaria that basically can kill you, and it's when the malaria goes to your brain and you get brain swelling and people stop breathing. So I'm thinking, oh, I want to order this, and this, and then I find out that I only can order these things. So we have limited lab access, and so I can get a hemoglobin, I can get a rapid malaria, but I already know that she's positive.